Hi, everyone. Welcome to our third session of the day and our last session of the day. We've got a wonderful presentations for you, and it's going to be on orthopedics and bone marrow transplant updates. My name is Steve Holland, and I'm father of 3 MPS1 attenuated children, and also currently serving as vice chair of the society. It's my pleasure to moderate for you today. We'll have 2 speakers, and then that'll be followed by a Q&A. So as they're making their presentations, please go ahead and use the Ask a Question feature on your screen to get the questions in. You can do it at any time during the presentations. That way they'll already be loaded up and ready for us when we get to the Q&A. So our first speaker is Klane White, MD. Dr. White is an orthopedist at Seattle Children's Hospital, an associate professor in the Department of Orthopedics and Sport Medicine at the University of Washington School of Medicine. He completed his internship and residency at the University of California in San Diego, where he also served as an NIH Fellow in Orthopedic and Basic Science Research. Dr. White completed a fellowship in pediatric orthopedics and scoliosis, here where I am in Texas, at Scottish Rite Hospital for Children in Dallas. His specialty interests include the treatment of pediatric hip disease, scoliosis, spinal deformity, and skeletal dysplasias, with a specific interest in MPS disorders, which of course is why we're so interested. Dr. White serves as chair of the National MPS Society Technical Research Committee and serves on its scientific advisory board. He is a former board member of the National MPS Society, and since today is Father's Day, I want to mention that he's the father of Madeline and Susanna. Susanna passed away several years ago with MPS 1. We welcome Dr. White, who will speak on orthopedic management of the Mucopolysaccharidoses. Dr. White.
Great. Yes, good afternoon, good morning if you happen to be on the West Coast like I am. Thank you, Steve, for the kind introduction. And I'd like to thank Terry and the rest of the staff of the MPS Society for, first of all, for everything they do in putting this great conference together and for inviting me to share some information with you all. So I've been asked to talk about orthopedic management and MPS. The title tends to change from year to year. The talk doesn't change too much because the science is a little slow to shift. So some of you may be familiar with some of this information already. So just standard disclosures, take everything I say with a grain of salt because I am an orthopedic surgeon. And by definition, that means we're strong as a bull and half as smart. And I do get some other support from different companies, but I won't be discussing any such treatments. So I'm going to give you an orthopedic perspective on how we care for children with MPS. But as Steve has already mentioned, I am a father of a girl who had MPS, Susanna. She died in 2008, but I think as you'll see, it's really rounded my professional career and helped me make all these friends in the MPS Society. For her, I was able to meet Steve and our next presenter, Dr. Orchard, 22 years ago now, believe it or not. So anyway, so with that in mind, let's move forward. I think it's always nice to start with just what do orthopedists do? Because I think there tends to be some confusion about how we approach children and or adults with any disorder, but specifically today, MPS. So the word orthopedics means to straighten a child. And so it's a little redundant that we're called pediatric orthopedic surgeons, but our role is the prevention and treatment of musculoskeletal disorders in children. And so we take care of bones and joints, so that's surgical and non-surgical. We're not like cardiac surgeons who have cardiologists or neurosurgeons who have neurologists. We are the operative and non-operative practitioners for these patients. And again, it's specific to children and in pediatrics, a lot of it is deformity. But in adults, it's more going to be joint disease and arthritis. So what is the role of the orthopedic surgeon? Well, what our goal is to maximize function and prevent disability. And we do that by preventing and or correcting deformities. We also take care of fractures. And again, as I already mentioned, we're involved in surgical and medical management. So what is the fundamental organ of the bone, of the growing bone? Well, it's the growth plate. So in medical terms, we call this a physis. And this is a cartilaginous plate at the ends of our long bones. So femurs, tibias, radius, humerus, and even our spine, as I'll show you. And this is the organ that's responsible for longitudinal bone growth. And when bone growth goes awry, then you can end up with crooked bones or bones that are shaped incorrectly. And this process is mediated through a very complex a network of not only endocrine, like growth hormone drivers, but also feedback loops within the cartilage, what we call paracrine pathways. And so this is just a cartoon of where the growth plate is, as I've just shown you, at the end of the long bone. And you can see there's a certain part of that growth plate that tends to be most affected by the lysosomal storage disorders, and specifically MPS and ML disorders. And we have similar growth plates in the spine. So because of this, we end up with deformities of the long bones, and we end up with deformities of the spine. And there's been some very elegant work done by Dr. Lila Simonaro, about why this happens. And so this is a very complex sort of, again, another process of how GAG fragments or glycosaminoglycans or mucopolysaccharides affect the paracrine pathway of TNF-alpha and interleukins and MMPs, and cause degeneration of the bone. And so if you look at this picture here, I'm not sure if I have a pointer or not, but you can see the arrows are pointing on the left to the normal bone, and on the far right to the MPS 7 bone. And then the bone in the middle is somewhere in the middle. It's a double knockout. So it's the inflammatory process has been knocked out, but it's an MPS bone. So you can see that there's a variety, you can see the cascade of effects there on bone growth. You may come across the term dysostosis multiplex. This is really just Greek term for multiple bad bones. And for some reason, it's been specifically applied to the MPS and ML disorders. And it's a diffuse skeletal disease, as I've kind of already alluded to. And it's mediated by glycosaminoglycans and an inflammatory process. In children, this results in progressive deformity of the bones, which is really not reversible. And for that matter, later in life, you end up with cartilage degeneration at the ends of the bones, which then results in arthritis. And you can have some residual deformity. And the issue with bone disease is that once it occurs, there's not a good way to make it return to normal with medical management. Certainly not in this time and place. And when you see your orthopedic surgeon, and he or she is speaking about deformity, these are some terms you should probably be familiar with. There's varus and valgus, which you can see on the left side of your screen. So normal is neutral alignment. Varus is when you have a deviation from midline, and valgus is when you have a deviation towards midline. So varus is bow legs, valgus is knock knees. And then you can have similar deformities in the elbow. When we talk about the spine, however, the coronal plane deformity is known as scoliosis. If we look from the side in what we call the sagittal plane, you can have what we call ray curvatum, which is a back knee gait. You can also have a flexion contracture, which is when the knee is stuck forward, which is actually we see more of in most of our MPS disorders. In Morchio, you might see more ligamentous laxity, so you might see that back knee gait. When we talk about the spine, however, that side plane is kyphosis, or you may hear about a gibbous deformity, and I'll be going over this later. And then there's also rotational changes. So within the legs, the way your feet turn in or turn out might be affected by the shape of the bones. And even within scoliosis, there is a three-dimensional twisting of the spine. So there's really three planes of deformity in every bone that can occur. Joint disease is a slightly different problem. And this we really see a little bit in maybe adolescence, but joint disease really becomes a problem in adults with MPS or ML. And so this is a nice cartoon, which is a normal bone and that glistening blue cartilage you see. And in the arthritic joint, you see the cartilage is all raggedy and broken down. You see inflammation of the joint capsule and fluid in the joint. So with that background, when you go to the orthopedic surgeon, you need to ask, what can you do for your child? What can that surgeon do for your child? Not what can they do to your child. It's very tempting to treat radiographic or even physical differences that may not have a functional implication. So if there is going to be a surgery entertained, it needs to make the child or the adult, as it may be, better and more functional, not just different. So you need to ask these questions. Will the intervention, whether this is medical or surgical, will it improve function? Will it decrease pain? And most importantly, will it increase my loved one's quality of life? There are many alternatives to surgery. Weight loss, as we all know, is a very important way to maintain a healthy living, especially when we talk about bones and joints. Sometimes you need an assistive device. You need a wheelchair, a walker, a cane. Many of my children, some with MPS, some with other conditions, we often prescribe motorized scooters, orthotics, braces, shoe inserts, and sometimes just pain-relieving medications, either by mouth or sometimes we'll inject pain-relieving medications directly into the joints. So these are all ways to try and avoid surgery that oftentimes can help you avoid surgery altogether. So when should we operate? Okay, well, pain and deformity that limits everyday activity, or at least is on such a regular basis that it affects your quality of life. There's pain, and this could be pain at rest, daytime, nighttime pain that keeps you from sleeping. Sometimes it's not necessarily painful, but stiffness that limits range of motion. But stiffness can be difficult to fix surgically, and so you have to be a little careful there. Or if we know that a problem is happening and we know it has an unfavorable natural history. So when we'll talk about hip disease, we know that hip disease might not be painful in children, but we know when they become adults that they will cause a problem. And this is a very complex spine, basically, or slide, I'm sorry, to show you that every MPS disorder, and I do not have ML included on here because this was an MPS chapter, but has some form of bone disease. And I'm going to go through all of these for you, so you don't really need to memorize that. So I'm going to start from the head and work my way down. And so we start at the top of the spine, and the most dreaded complication, particularly for Morquio syndrome, but we also see it in other forms of MPS, is narrowing of the spinal canal at the neck. So we call this cervical stenosis. And this can be due to several reasons. First of all, the bones in MPS and ML tend to be smaller. So the canal, which carries the spinal cord, is smaller in caliber, and there's not as much room for the spinal cord because the spinal cord will be the same size. In fact, it might even be larger than normal. And so the upper cervical vertebra, we call C1, the first cervical vertebra, is a ring. And so that can be small and pinch on the nerves. You also can have thickening of the soft tissues, and I'll show you an MRI that demonstrates this in a minute. And then for certain conditions, you can have a certain amount of ligamentous laxity, again, specifically Morquio syndrome, where the bones, the two top rings, the C1 and C2, can actually move on each other and pinch the spinal cord even more. So it takes a very tight situation and makes it tighter. And this is just an example of a child with MPS 6. And you can see here on your left slide, you can see that ring of C1 is sliding forward. And if you look on the MRI on the right, there's an arrow pointing a little blush in the spinal cord. This is the same patient. It's narrowed spinal canal. And that blush in the spinal cord is actually a bruise to the spinal cord. And so this child was walking. He was 2 years old, fell backwards, and actually was temporarily paralyzed and luckily recovered function. In some MPS disorders, we don't necessarily have instability. We just have thickening of the canal. So glycosaminoglycans can build up in any part of the body, and that can be in what we call the dura, which is the lining to the spinal canal, can be thickened. And so and not only do you have small bones, but you have soft tissue thickening that then impinges the spinal canal. And so here's an MRI where you can see, what you should be seeing is down below, you see a lot of white fluid around the spinal cord. And then right in the neck, it's very pinched. There's no fluid. There's no room for fluid to get through there. And so we see this in the more attenuated forms of MPS 1, and we see it commonly in MPS 6 as well. So what are the symptoms of spinal cord compression? Well, myelopathy is the medical term. And what that means is weakness, clumsiness, loss of balance, and unsteady gait, and in really significant situations, loss of bowel and bladder control. People with instability of their neck will complain of neck pain and headaches because usually their muscles will be spasming, trying to hold their bones in place. How do we treat this? Well, we typically will do a decompression of the spinal canal, and then we'll do a fusion. And so here in this x-ray, you see where we put implants to stabilize the bones, and then we put bone graft in, which is actually the fusion. And so we recommend surgery, again, when there's a problem. There's neurologic changes, there's clear instability, which may be not a problem, but it will portend a problem. As I mentioned, we know the natural history of that is unfavorable. Or if there's any evidence of past injury on MRI, as I showed you earlier. Moving down the spine a little bit, in many MPS disorders, we have what's called a gibbous deformity. So you can see in this little girl, the bump on her back. And quite honestly, this is how probably 90% of our hurler kids present and are brought to our attention. It's the most common spinal deformity in MPS. We see it in all forms of MPS, not just Hurler syndrome. It's not always progressive, so it does not always need to be treated. Bracing, we can try to, it's more of a delay tactic. It doesn't treat it. It's not going to cure the problem. But it can be useful and helpful. We know that deformities that reach a certain threshold tend to get worse over time. That number is around 45 degrees, as has been studied by the group in Manchester, England. So how do we treat this? Well, for kyphosis, you can see on this slide that round back. We do a fusion in the front and the back. We put instrumentation in the back. We want to achieve a stable and balanced spine. And from this, we can get a very nice outcome. Oftentimes, the children will need a cast or a brace for 3 to 6 months afterwards, depending on how small the child is and how confident the surgeon is that the screws and rods are going to hold in place. And this is just another example of that surgery where we had to do a little bit more implants because it was a bigger deformity. And so you can see, it's hard to see the x-ray on the left, but you clearly on the MRI in the middle, you can see the deformity and then the post-surgical outcome. Now, scoliosis is much less common. Now, this is a child with Morquio syndrome who has a very severe scoliosis. You can see that rotational deformity, the rib hump on the right side, looking at this patient from the back. There's a big rotational component to this. So the spine is turning to the right, rotating to the right. Now, scoliosis doesn't tend to cause neurologic problems, but it does cause pulmonary problems. And this is just an example of, scoliosis from the front. You can see a little bit of a kyphosis as well associated with this. And this is a more typical surgery for scoliosis where we have to do a long instrumentation and fusion. Moving down to the hips, the x-ray on the left is what a normal child's hip x-ray should look like. The x-ray on the right is a child with MPS 1. And I'm going to go through with you what the difference is. So we see what's called a break in Shenton's line. So that's the femoral neck is sliding upward from the dotted line. The shape of the neck is actually has a very high, what we call neck shaft angle. And then we have a very shallow acetabulum as shown here. And then what that results is in the femur sliding out of the hip socket. And so we treat this by doing surgery to deepen the hip socket, which you can see that little spreader in there, deepening, hinging down the hip socket. And I've already cut the bone down below to direct the femur into the hip joint. And this was probably about a year later. And then over time, the bone heals in, the hips are nicely seated. But this is a child with Morquio syndrome. And over time, while the hips are stable and she's painless, you can see that there's no real bone. The hips are still not normal looking. And so this child is eventually going to require a hip replacement. And here's an MRI showing that cartilage. It's a little hard to see here, but again, there's a cartilaginous head, which is sitting in the hip joint. So over time, we see that femoral head erosion. And this is a child who had not had surgery. And you can see that on our right side, but the patient's left, that hip is sliding out of socket. And this is going to result in painful arthritis. So I think we operate when we think there's going to be a problem. And that's just basically what this paper says. I think surgery is not a panacea. if you look at the Minnesota group's follow up on this, with by far the largest study of the patient, of the 100 hips that they operated on, 3 developed arthritis who had surgery and 2 who didn't have surgery. So the outcomes are somewhat similar, although it's a little hard to be sure exactly in a retrospective setup. This is the Irish outcomes, and you can see in this yellow box, you see arthritis in the left hip and the right hip, and many of these have advanced arthritis 10 to 15 years out, despite having surgery. So surgery is a short-term fix. There are some benefits to surgery aside from trying to avoid arthritis. But in general, my feeling is that patients do better if they've had surgery. Knock knees, very common in MPS, and it's very responsive to what we call guided growth. You may have heard the term 8 plates. 8 plates is actually a brand name. And what you see are these little plates that we put in the knees. This is a patient who is knock-kneed and actually slightly overcorrected because we worry about what's called a rebound. And so, but this patient went from being knock-kneed to slightly bow-legged and eventually straightened out. There are many ways to straighten the legs, and this is just an X-ray from the DuPont group where the patient had knock knees, had osteotomies or bone cuts to straighten the bones, had the hips done, redeveloped knock knees, and then had the guided growth down here in this F. And then in the end had a very nice outcome with straight legs and hips that were well stabilized. And I think bang for your buck, guided growth for the knees is probably the best operation we can do in MPS. It has the best result with regard to improving function, and it's the least risky of the surgeries we do. Moving on to the hands, carpal tunnel syndrome is extremely common, and we see trigger fingers more commonly in our hurler kids. And this is because of thickening of the lining of the tendons, and it pinches the nerve that goes through the carpal canal, which results in numbness and tingling in the hands and weakness in the hands. Oftentimes it can be painful, but most often it's not. And so our children don't even know that it's happening. And so because of that, and this is just a cartoon of the carpal canal, is that these are the symptoms that the children develop: alterations of play, clumsiness, shaking the hands, gnawing hands. But we do recommend nerve conduction studies on a regular basis, particularly in our younger children and those children who are not able to tell us about symptoms because they have difficulties with communications. They can be followed by a hand therapist who can help you decide whether there's something going on. But in the end, if there's any change in nerve function, we recommend very quickly that they have surgery. A little brief synopsis of medical management and how it affects the bones and joints. Well, stem cell transplant, which Dr. Orchard is going to get into, so I'll try and skip over this a little bit. But we know that I think it probably helps the bones and joints, specifically in MPS 1 hurler, but there's still some residual deformities that we have to take care of. And so on the left of your slide here is a child who's untreated, and on the right are 2 children who have been treated. So we know stem cell transplant really helps our children. And if we look at their hips, however, we know that their hips get worse. So the dotted line in this graph on the left is what normal hips do, and and the colored markers are the hips with kids who had transplants. And the box plot to the right shows that relative to the 0 line, which is where they should be, the angles get worse with time. And so we know these hips are going to get worse, which is why we recommend surgery. We know that spinal cord compression is more common in children who are transplanted at an older age, who have less enzyme, as with carpal tunnel syndrome. So younger transplants, better enzyme helps. And I don't want to steal Dr. Orchard's thunder too much, so I'm sure he'll go into that in more detail. Enzyme replacement therapy in MPS, it does improve musculoskeletal function. It reduces joint stiffness, but probably has no real effect on the actual bone disease. Now, there are some papers out there that suggest if you start enzyme replacement therapy as an infant, that there are some improvements, and we have some siblings. And I think you can see the facial features are certainly different on these 2 siblings. The girl on the left was started at 3.5 years of age. The younger brother was started at infancy. Their X-rays, his X-rays are better. He just looks less affected. So there's certainly some reason to think. And here's out of Japan, 10-year follow-up. The x-rays really kind of look the same. These kids, they tried to say that they were better, but I didn't really buy it. But again, you can see the improvements in facial features in the sister compared to the brother. As far as gene therapy goes, still haven't demonstrated any real benefits from gene therapy on the bones and joints. So in the mouse model, at least, you can see the red. The survival is red. Is the blue is the mice who were treated. The red is those who weren't. So the mice clearly survived quite a bit longer. But when you look at their bones and joints, comparing the MPS treated versus untreated, which are the bottom two groupings, they're really no different. So I think we're still waiting on there. So the real question is, does orthopedic surgery improve the quality of life and function in MPS patients with MPS? So what this slide says is that it may improve function and quality of life. And again, I think knee surgery certainly does. I think cervical spine surgery does. I think those are indisputable. Some of the lower spine surgery, the gibbous deformity, hip surgery, maybe not. And I should say carpal tunnel syndrome, I think very much does. So it's a mixed bag. The research isn't great, but I think I'm convinced that surgery has a role in caring for these. Last thing I'm just going to point out is that if you or your child or other loved one is going to have surgery, for any elective surgery, they make sure that your loved one has a thorough preoperative evaluation for their lungs, their heart, and their upper airway. They should see an otolaryngologist. Someone needs to be familiar with their airway to stay out of trouble. You need to go to a center where they are used to taking care of kids who have this problem. They need to have skilled airway personnel and equipment. And for children who are undergoing even lower extremity surgery, non-spinal surgery, they should have neuromonitoring. And this is just an example of that. This is a child I took care of now 12 years ago who had a beautiful hip surgery, had this deformity of the spine, and woke up paralyzed because we didn't know about this problem. And now I can tell you there are 15 to 20 children across the country who have had limb alignment surgery or hip surgery with MPS who have woken up paralyzed. So you need to be aware of this. So in summary, we know MPS results in significant skeletal disease. It's deformity and joint disease. I think surgery is often required and helpful. Medical therapies at this point are insufficient, but I'm still hopeful that we can develop better therapies, small molecule therapies and such, which might be able to penetrate that growth plate that I showed you at the beginning of the talk and result in a better outcome. So with that, I would like to thank you for your attention, and I will be staying on for questions after Dr. Orchard's presentation. Thank you.
Thank you, Dr. White. Very informative, very interesting. And on behalf of us parents, the laymen, the non-doctors, we especially appreciate the X-ray photographs, all the visuals, because it really makes that come home for us and more meaningful. So our next speaker, or let me encourage you to get your questions submitted. Go ahead from Dr. White's presentation and get the questions written in and sent over to us so we can start processing those. And then our next speaker is Paul Orchard, who's an MD in Minnesota. Dr. Orchard is the medical director of the Inherited Metabolic and Storage Disease Transplantation Program and a professor in the Department of Pediatrics in the BMT division of the University of Minnesota. He is interested in the use of hematopoietic stem cell transplantation and other cell therapies, including gene therapy, to improve outcomes. Dr. Orchard is engaged in research designed to identify strategies that enhance the delivery of enzymes to the brain and the peripheral nervous system. Other interests include the modification of stem cell transplant approaches and combination therapies to improve outcomes for patients with inherited diseases, and the potential to develop multi-institutional cooperative studies for these disorders. Again, in honor of Father's Day, Dr. Orchard is the father of 3 children. We want to honor him for that. And he will speak on bone marrow transplantation and updates for MPS disorders.
Hi, everyone. This is Paul Orchard from the University of Minnesota. Appreciate the opportunity to talk with you today. I'd like to focus primarily on the use of transplant for Hurler syndrome, but I'm going to talk a little bit about some of the other MPS disorders as well. And then towards the end of the talk about some other opportunities that may be available for therapy moving forward. So I'd like to start with how we got to trying transplantation for diseases such as Hurler. And really the basis of this was established back in 1968 when Liz Neufeld's laboratory reported some of her findings. So in this circumstance, they had cells from patients with Hunter or Hurler, and they accumulate glycosaminoglycans within the cells. But if you mix those cells, looking at the blue arrows here, you mix those cells with normal cells or even the Hunter cells and Hurler cells together, that accumulation of glycosaminoglycan essentially goes away. So this was termed cross-correction and was really the basis for why transplant was explored for this type of disease and for a number of lysosomal disorders. So in terms of the clinical history, the first transplant was done in Bristol in the UK. It was a Hurler patient. It was reported in Lancet in 1981. I think the transplant itself was done in 78. For instance, the mother was used as a donor in that circumstance, and they were able to show that enzyme levels increased and glycosaminoglycan levels decreased. The liver and spleen got smaller. They thought there was improvement in the eyes and that the neurologic function of the patient was preserved in comparison to what they would otherwise expect. So this really opened the door to using or exploring transplant for a number of these lysosomal disorders. The first transplant that I'm aware of that was done in the US was actually done here, not in a Hurler patient, but in an MPS 6 patient. And this was in the New England Journal. And then a number of other lysosomal disorders were explored from there. But Bill Crivet, who was a mentor of mine, was really on the ground floor of using transplant for these types of disorders. So virtually all these genes have now been identified and cloned, and you can make pharmaceutical grade enzymes. So why are we still using transplant for these disorders? And again, if we provide someone else's blood cells, they have the opportunity to provide enzyme for the cells that are deficient and potentially help improve the disease on that basis. There's also the opportunity for those cells to get through the blood-brain barrier into the brain, and that these blood-derived cells can provide enzyme to neurons, astrocytes, and other cells within the central nervous system. So there's an opportunity to benefit the patient in terms of neurologic function that is much less effective using intravenous enzyme therapy, because enzyme, those are large molecules. They don't penetrate through the blood-brain barrier into the brain, and so really are much less effective at treating the brain. So I'd like to talk for a few minutes about how transplant is currently being used for the MPS disorders. MPS 1 actually broken down into the severe form or Hurler and the attenuated form. In terms of Hurler, transplant really has been the standard of care. We've been using enzyme therapy in association with transplant, especially for the patients while we're setting the transplant up. So usually they get several months of therapy with enzyme before they get to transplant. For the attenuated patients, because they don't have the neurologic issues that the Hurler kids do, transplant, because it has significant risks, is generally not. So as one can imagine, because it's a continuum between the severely affected patients and the patients that are less affected. There may be patients that have subtle neurologic issues that might potentially benefit from transplant. That's a small population of patients. People have asked me if the safety associated with transplant continues to improve, would there be a role for transplant for attenuated disease patients? And possibly, but it's not been something we've been using for that population of patients, at least thus far. In terms of the Hunter patients, so Hunter is somewhat difficult. Generally, we don't transplant those patients. It's difficult to determine for a number of these Hunter patients who's going to get a neurologic phenotype, because not all of them do. And if you're going to intervene with transplant to help preserve cognition, you need to know this very early. So how can we establish which patients would potentially benefit from transplant has been problematic. Certainly, if we can identify the patients by newborn screening, for instance, or because they had a prior brother that's had MPS 2, we can have a better sense of what the disease would look like for a particular patient. But otherwise, we don't have great tests that will help us determine which patients are going to be at risk for the neurocognitive issues. And so that's it's been problematic in terms of the hunter population. I just wanted to mention briefly that in Japan, hunter is a bit more common, and they have published their outcomes with transplant in their hunter experience. It's 146 patients that were reported in this study. They compared the GAG levels and some of the outcomes with the patients that were on enzyme and suggested that the GAG levels were lower. MRI-based imaging looks actually better. And in activity of daily living, for instance, the transplanted patients do better. However, as there is significant risk with transplant, at least in the US, that's not been a major focus for those patients. Marrow patients, unfortunately, transplant does not seem to help. And so we generally do not use transplant for that group. Unfortunately, it doesn't provide significant benefit, and it's not worth the risk to patients. Morquio patients, again, we don't generally do transplant for that population of kids. So again, it has been done in Japan, and they have suggested that actually some of those patients that were transplanted may actually do a bit better than if they'd received some enzyme. Because there's no intrinsic neurologic issues associated with the MPS 4 patients, like there is for Hurler, for instance, generally don't go to transplant for that population of patients just because of the inherent risks of the transplant. For MPS 6, as I mentioned, transplant is reasonable therapy, but those patients also don't have the neurologic disease that the Hurler kids do. And so justifying the risk of transplant has been harder. Whether or not transplant might provide better outcomes than enzyme hasn't really been studied, and it would be difficult to do. So generally speaking, the Marrow patients, we aren't transplanting either. Now, there's some data in the SLY patients, in the animal data, that transplant could provide some benefit for that population of patients. It's a very small group of patients just because of the rarity of the disease. So there's really very little clinical information in regards to this, and most of these patients just go on enzyme at this point. So I'd like to talk a bit, focusing more on Hurler and what the experience is with transplant and how these patients do, risk benefits, and then limitations of the procedure as well. So Be the Match is the group that helps us identify donors if there's not a brother or sister, for instance, in the family. They also collect data of who is transplanting patients with what diseases. And so we went to them to try to better understand where these patients are actually being transplanted. So anyone who has gone through a unrelated cord blood or unrelated donor transplant, and that data has gotten reported to the Be the Match group, is reflected here as 447 patients that they had reported. And of those, we've at Minnesota done 109 of those patients, so 24%. And there's 151 other centers in that group. So just wanted to make the point that this has been a focus of ours. And again, this is going back to the 80s when Elsa Shapiro and Bill Krivet were exploring transplant for these types of disorders. And we continue to be focused and committed to that population of patients. So this is data regarding outcomes and survival of patients with Hurler that are treated either by enzyme or transplantation. So the untreated population of patients there is depicted. So the vast majority of these patients, probably 90+% of them, die generally of cardiopulmonary related issues by the time they're 10 if they don't get any therapy. When enzyme therapy became available in 2004, there were a group of patients where the families decided for whatever reason not to pursue transplant and just have those patients go on enzyme. So their survival is shown here as well as compared to the patients that have been treated with transplant. So as you can see, there's statistically improved survival in the transplanted patients versus those that just get enzyme. We also asked the question, being as we've been transplanting these patients since the 80s, what's the long-term survival look like? And that's shown here, are the patients that we could gather data on. So on the left side of this curve, you can see there's a quite steep drop off, which is essentially peri-transplant mortality. And again, this goes back, 30 plus years. So a number of the patients died going through the transplant, but the other key piece here is that this curve isn't flat. So these patients, even having gone through transplant, continue to die over 10, 15, 20, 30 years. Exactly what they're dying of, that data is hard to obtain. We think some of this is still cardiopulmonary issues, but it's difficult to get to. But The point is that despite survival being quite significantly improved with transplant, we're not curing these patients. This is data from a multi-institutional study. A number of the large groups that transplant the Hurler patients compiled data, and that's reflected on a few of the slides I'm going to show you. I think there was 258 patients essentially in this study. The study's a bit old now, but the data is, I think, important. The point of this slide is that if you look at the earliest population of patients, there are 53 patients transplanted before 1999, you can see what their survival looks like in that group, as opposed to patients that were transplanted more recently. And so essentially what I want to convey to you is that over time, the risks of transplant have decreased, although it continues to be significant. And generally, I would say that peri-transplant mortality, I mean, having someone die from their transplant, is still about 15%. So we've come a long way, but transplant still has significant risks. This looked at that same population of patients. The median age at transplant was 16.7 months. So essentially, just got divided into two groups. They compared the survival in the patients that were transplanted earlier versus those that were transplanted later. And as you can see from this, the kids that were transplanted younger had an improved survival over those that were older at the time of transplant. So we've been talking about survival, although one of the key things I think that's important to recognize, especially for diseases such as Hurler, is there's multi-organ system issues. And we want to impact all these as best we can, but you probably need to pull each of these out and look at how well your therapy is doing. So this compares a bit enzyme therapy on the right to transplant on the left, and the red arrows suggest there's a good benefit, the blue kind of intermediate, and then the yellow less. So for instance, the central nervous system is reasonably impacted by transplant, whereas for enzyme therapy, it's really not. Let's talk in the next few slides about the central nervous system disease in Hurler patients. So this is somewhat old data, but this is what the predicted neurocognitive function looks like in the kids that have Hurler syndrome. So as best we can tell, the kids that are very early in life, maybe out to 6 months or so, tend to be quite normal in terms of their IQs, but over time they get further and further behind their peers and lose significant ground. In the same study that we were talking about before, multi-institutional study, they looked a bit at outcomes in terms of how these patients have done. So if we define a normal IQ as greater than 85, 56.9% of the patients had a normal IQ at the time that they're going into transplant. But if you look several years after transplant, it was only 26.9% of those kids that had a normal IQ. So what we tended to see with transplant is that the kids lose ground in the first year or so as they go through transplant and then appear to stabilize reasonably. But this loss of IQ over the transplant period is key and is something that we really need to focus on. So for instance, if we look several years out after transplant, 44.9% of the patients were severely affected. The boys didn't do as well as the girls did. If you came into transplant with a relatively low IQ, or if you were older, you didn't do as well. And if radiation was used in the treatment regimen, which hasn't been used for extended period of time, but again, this goes back quite a ways, but those kids didn't do as well either. So I wanted to briefly talk about the skeletal disease associated with her. And, Klane White is the international expert in how these patients do in terms of the skeleton. So, but I just wanted to make the point that even if you've gone through transplant and even if you're engrafted, meaning you have donor cells, that does not fix your skeletal disease. Relatively high proportion of these kids go on to need carpal tunnel surgery. They have significant kyphosis that may need to be corrected, or at least an intervention made. They have hip issues, they have knee issues. Some of them even develop cord compression. So from the skeletal standpoint as well, transplant is not curative. So we can look at this in a little more detail. So this just focuses on carpal tunnel. But if you are younger at the time of transplant, it appears that you may be less likely to require carpal tunnel surgery. And this looks at carpal tunnel surgery by enzyme level. So some of the kids in the study had relatively low enzyme levels, and they were more likely to need carpal tunnel surgery than those that had higher enzyme levels. So there's somewhat of a dose effect in terms of benefits of enzyme. So what can we do to make this better? Can we make transplants safer? Can we make the outcomes better? I think one of the key things is going to be newborn screening. I don't think there's any question that if we can identify these patients earlier before they've lost cognitive function and they've had other related issues, that is going to be a great benefit. Is interested in further decreasing the toxicity of transplant by modifying the chemotherapy regimen. And so we've been interested in this for an extended period of time, but we're still modifying transplants. One opportunity now exists to essentially, from the bone marrow of an unrelated donor, for instance, pull out the cells that are more likely to cause graft versus host disease and increase safety on that basis. It also may allow us to get by with less immune suppression, and so may decrease the risk of infectious complications. So that's something that we're currently working on. And this is further in the future, but there are also interest in developing antibodies that can help eliminate the blood stem cells and other blood cells within the bone marrow. And if we can do that, that will be a less toxic way of clearing out the bone marrow, making room for the new cells. So that's something we're also interested in looking at, although again, these things are just starting to get explored. It'll be years before we'll be able to study that in earnest. So I think I made the point that transplant, as a bone marrow transplant person, it's very clear to me that transplant is insufficient and we need things better. If we can identify the kids earlier, that will help. If we can deliver more enzyme, that will help. But we don't have a way of upregulating the amount of enzyme that a cord blood graft or unrelated bone marrow, for instance, are going to provide. One way to potentially do that would be with gene therapy. So is there an opportunity to make things better with gene therapy? This is animal data using a lentiviral-based approach in treating mice. And I just wanted to show you some of the background here. So on these two figures on the left, the hurler mice, who have similar issues as the kids, have very little enzyme, as you might expect. So those are the black dots here. If you transplant the hurler mice, those are the green dots. And you can see there's substantially more enzyme in the blood than if they're untreated. And it's reasonably close to the blue dots there, which are normal mice. But if you look at the orange dots, so those are mice that are transplanted with blood stem cells that have been engineered to make enzyme. And as you can see, this is a log scale. So there's a lot of enzyme that these cells are producing. And if you look at the right figure here, so the gene therapy, again, is in the orange, and enzyme levels are high, but it's also quite sustained, which is really the point of this one. So out to 6 months after gene therapy, which is pretty long stretch of time in a mouse, there's still a lot of enzyme there. And there's different ways of looking at how these animals benefit, but one of them is looking at lysosomal size. That's what this figure is. Black bars are the untreated hurler mice. The green bars are those that are treated with bone marrow transplant using normal cells. And those that are treated with gene therapy are in orange. So as you can see, for a number of the different organs, transplant may be beneficial, but it doesn't eliminate the accumulation of storage material in the lysosome as well as gene therapy does. So what about gene therapy in patients with hurler? The same lentiviral-based gene therapy is now being explored for the hurler kids. And I just wanted to kind of outline the process here a bit. So we need blood stem cells. And again, we're not using somebody else's cells here. We're engineering the kids' own cells, but we have to be able to access them. So there's a process called apheresis, or hematopoietic stem cell collection. So on the left here, we use GCSF, granulocyte colony stimulating factor, and plerixafor to release the blood stem cells out of the bone marrow where they primarily live so we can collect them. So following that process, the cells get shipped for manufacturing. There's a virus that's engineered to make enzyme, and it's actually based on the HIV virus. So that virus is used to transduce the cells or infect the cells, and then the cells are stored and frozen. There's a lot of quality control pieces that they do to make sure the cells were engineered efficiently and there's no infectious issues, and et cetera. So that can take a month or 6 weeks, and then we can, following the arrival of the engineered cells, we would provide busulfan, which is really the chemotherapy. And then, having eliminated the cells that weren't making enzyme, we can infuse the cells that are. And so those cells can circulate through the body and provide enzyme. Hopefully some of those cells will make their way into the brain and treat the central nervous system as well. So a lot of these protocols are set up as a 2 or 3 year follow-up protocol to see how the patients are doing. But the FDA now requires patients that are undergoing gene therapy to follow for up to 15 years. So this is a long-term commitment. So there was some data presented several months ago at one of the meetings about the preliminary outcomes for the patients treated in Milan with Hurler syndrome by lentiviral-based gene therapy. And I just wanted to share this with you briefly. There's 8 patients that have been treated. The study is not open anymore. They're just going to do these 8 patients and then follow them along. Busulfan and fludarabine were used as the chemotherapy agents, and then the patients were reinfused with their own cells. There's a bit of data in terms of the amount of enzyme produced here in the middle. The upper curve is how much enzyme is present in the spinal fluid, and you can see that it goes from essentially 0 prior to treatment to significant amounts of enzyme. And there's a lot of variation here, as you can see as well. And in the lower curve, the amount of enzyme that's produced in the spinal fluid and the GAGs that are related to that are depicted here. So the enzyme levels actually in red, and that's the compilation of enzyme in the patients. And the blue curves are the amount of glycosaminoglycans, which fall over a period of time after the gene therapy. So it suggests that not only enzyme is available in spinal fluid, but that the amount of storage material is decreased. They looked at neurocognitive outcomes in terms of Bailey, neuropsychologic based testing. And the patients don't gain function, but they don't look to be losing function either. And it's clear that there's only a few patients here to look at, and the time is short. So I don't want to overstate this really at all, except perhaps to say that it looks encouraging. There's another study that's, I think, still open using a different viral platform called adeno-associated virus. And REGENXBIO is doing this. The study before was actually sponsored by Orchard Therapeutics. It's not my company, but they're the ones that were using the lentiviral-based approach. This is REGENXBIO. The adeno-associated virus, again, has the IDUA gene in it. This is focused primarily on the neurocognitive aspects of the disease. So the virus is actually injected into the spinal fluid in a little pocket called the cisterna magna at the back of the brain. That virus then can distribute itself through the brain and provide enzyme. And that's really the focus here. And they're doing this for other disorders like MPS 2 actually as well. Whether or not sufficient virus or enzyme will make its way out of the brain and actually sufficiently treat the entire body, it's going to be an open question. They're only going to treat 5 patients. They've treated at least 3 is my understanding. So I don't know if there's more opportunity to treat patients or not. I think so. This is open at Children's Hospital of Philadelphia, at UCLA, and at Penn. You need to be at least 4 months old. You can be post-transplant for families that are potentially interested in this. But this, again, is for the Hurler population. There's another platform for gene therapy that is being explored, and Sleeping Beauty is actually the term for this. It's a transposon-based system. So this is a DNA-based system as opposed to a viral one, which we've been talking about for the last 2. Bit of a different mechanism to introduce the IDUA gene. It's not open yet clinically. So this is data from the mice, but again, in the Hurler mice, the blue curve here is the number of cells that we're anticipating potentially giving to the patients. Rather than going after the blood stem cells, this actually just looks at the B cells. So that's going to be the focus here. So we're developing this in association with Immusoft. We initially put a proposal together to treat the post-transplant Hurler kids, see if we can boost the amount of enzymes that are present. The FDA, as they often do, has requested that adults get treated first. So there'll be at least a few patients that are adults. And again, I think they will be able to be post-transplant patients if people are interested in exploring this. And then the idea would be, if it looks like there's a safety profile, it's okay, then would be potentially expanded to kids. So we're hoping in the next year or so, this will get off the ground, maybe hopefully a little earlier than that. But this is another therapy that might be available. And this is essentially how this is done. So again, we have to obtain the cells that we're trying to engineer. We're not going after the blood stem cells here, so we don't have to use the granulocyte colony stimulating factor, And for Lixophora, we're just getting the cells essentially out of the blood. But again, we use this apheresis procedure to do that. Then rather than using a virus, it's actually an electroporation system. So current is passed across the cells and it allows the transposon to get into the cells and provide enzyme production. And then the cells will be reinfused to the patients. And there's no chemotherapy associated with this protocol. So in summary, I envision transplant as perhaps the best thing that we have now, but it is inadequate for therapy. I think it's clear. We can tweak what we're doing with transplant to try to make it increase the safety, but we can't really ratchet up how much enzyme is being produced. It's the normal cells that are given, whether from a brother or sister or an unrelated donor or cord blood, will only make as much enzyme as they can make. Newborn screening will be important in terms of being able to access the patients early and intervene before a lot of damage has been done. Again, I don't think there's any question. But gene therapy is coming and is actually here. Adenovirus-based gene therapy study has been open. The lentiviral-based study was piloted in Europe. We're certainly interested in whether this might be something we can offer in the US, but that's very early. Sleeping Beauty protocol using the transposon system is developed by Imisoft. It's something that we hope to be able to offer soon. And I just wanted to mention too that the gene therapy for Hunter and for Merito-Lemay and other disorders will likely be offered. And there are some studies ongoing, for instance, in both of those diseases as well. So again, I very much appreciate the opportunity to talk with you today. And please feel free to contact me if there's questions or any other information I can provide following.
Okay, thank you, Dr. Orchard, for that presentation. And thank you again for using lots of visuals that make the data so much clearer for us as parents. I also want to commend you on your ability to move from sentence to sentence without breathing. Obviously, that presentation was taped and it was cut a little bit for length, and so some of the time was sped up.
Yeah, so, it's not too surprising. I talked a little over here, so yeah, they did a little editing, so it made it a little choppy. So
all right, great. So now we're moving into the Q&A, and thank you. We've received a number of questions, and we'll get to as many of those as we can. And also, I want to try to commit on behalf of the society. For those that we do not get to, we will try to email you answers. We do have your email address and who sent that in. So if we don't get to it live, then we will still try to get those to you. And you can continue to submit questions, so please do that. So first, for Dr. White, we're trying to figure out the cause of increased intracranial pressure in my child, and there is some thought that it may be attributable to compression in this cervical spine. If we have the spine corrected, can that improve the flow of the CSF?
Well, that's a tough question. I would say that generally it might help, but that's typically not the primary cause for hydrocephalus in MPS. It has the fluid dynamic. I'm not a neurosurgeon, but my understanding is that the CSF flow, and Dr. Orchard could probably comment on this more than I can about how the CSF dynamics go, but the reuptake of CSF within the brain is limited. Now, we do know in other conditions like achondroplasia, where you do a foramen magnum decompression, that can sometimes offer relief, but of hydrocephalus type symptoms. But it's not certainly something that I would count on or use as a primary mode of treatment. I think there are two different situations that both need to be dealt with and probably approached independently. And if you're lucky enough to be able to kill two birds with one stone, then I think that would be lucky.
Okay.
Yeah, I just chime in too. So I don't know that we know, well, I certainly don't know as much as I'd like to about why some of these kids get hydrocephalus, but even when some of these kids present to us at a few months of age, some of these kids have high intracranial pressure. So I don't know that it's because of the orthopedic issues that have developed over a substantial period of time, for instance. So I'm sure it's multifactorial, but again, I wouldn't necessarily attribute it to only orthopedic related issues.
Okay, great. Move on to our second question again for you, Dr. White, at least to begin with, and Yeah, those can chime in. My son has MPS 6 and has had a cervical decompression at age 2 in 2013. They did not fuse at that point to allow optimal growth. Would you expect that he will need to be fused at some point down the road? He is now 10 years old, so 8 years since it was done.
Yeah, that's an interesting question of which we don't totally know the answer to, and especially for MPS 6. There is some literature out there for Morquio syndrome that if you only do a decompression without a fusion, that the recurrence rate is about 50% over the course of 5 to 10 years. Now, Morquio syndrome is very different because they have a much higher, they have much more ligamentous laxity. And so for Morquio syndrome, I strongly recommend that a fusion be done. But for Hunter syndrome and MPS 6, and even MPS 1 for that matter, where there's less issues with ligamentous laxity, they tend to be stiffer. I think the jury's out. And so I think monitoring is appropriate, but I wouldn't necessarily expect that the child's going to have a problem in the future.
Okay, thank you very much. Dr. Orchard, for you, we're hearing about kids who are losing engraftment and have to have second transplants. How common is this, and is the process different when you go through it a second time?
Well, so there's a number of issues that can make a difference in terms of whether you have graft failure, which essentially means that you recover your own cell population as opposed to the donors. How well you are matched ends up being an issue, because if you're mismatched, like a mismatched cord blood graft, for instance, the chance of rejecting those cells over time is higher. One of the things that we've been trying to optimize in the last 20 plus years is how much chemotherapy do you really need to give? And the more chemotherapy you give, the better the chance is that the donor cells are going to take and be 100% for a long period of time. If there's more toxicity, the more chemotherapy you give. So whether you can dial back a bit how much chemotherapy you need ends up playing a role there as well. So, we'd like to figure out how to thread that needle essentially and give the minimal amount of chemotherapy that we need to ensure that, as best we can, that the cells will remain donor derived. But it's something we're continuously modifying, essentially. In terms of the second transplant, so it depends a bit. If it's quite early on top of the first transplant, then we tend to scale back again the amount of chemotherapy that we give. The immune system hasn't fully recovered, and you don't likely need as much chemotherapy. But if the patient is several years out, we'd probably use essentially the same chemotherapy approaches we would for a first transplant. So, but we recognize that having to do it again, the risks are higher, having gone through the first procedure. So, it is a bit different from that standpoint.
Okay, thank you. Dr. Orchard, another question. Could you please talk about transplant for Hunter with neurologic issues? I have a newly diagnosed son, 5 years old, and he is developmentally on the level of a 2 to 3 year old.
Well, there's a lot we don't understand about how transplant works for these diseases. So just globally, transplant works better for MPS 1 than it does for MPS 2, and it doesn't really work very well at all for MPS 3. And exactly why that is still not clear to me. The chemotherapy we use is the same. The cells we use are the same. Presumptively, you just have to deliver more enzyme for MPS 3 than you do for MPS 2. So, there are some variations there. But I think for all those disorders, if you've lost ground cognitively, we don't have a way of recovering that. And so whatever deficits that have occurred related to the disease process, we don't have a way of making those things better. So really all we can hope to do is slow the progress of the disease. So, transplant is likely to do that better than giving enzyme. But if somebody's already lost, a fair amount of function, we'd have to really discuss what our goals are going to be of the transplant, because it's a significant risk to put someone through a transplant, clearly.
Okay, thank you. Dr. White, from the time of hip reconstruction to the time of hip replacement, about how long approximately would you put in between these two surgical interventions?
Well, it largely depends on when you do the first intervention, really, to be honest. But I would say that having a hip reconstruction as a child will most likely buy you until the early 20s that hip replacement would be needed. So there's a couple, the benefits to doing the hip surgery as a child are twofold. One, some of our kids actually become quite symptomatic, again, especially in Morquio syndrome. And by stabilizing their hips, we can reduce their pain. When we perform it in a more prophylactic fashion, as I do in MPS 1 hurler, they're not symptomatic, but we generally do them younger, so they're going to get more time. So the second benefit of it is that it actually gives you better anatomy for that hip replacement. There's more bone stock available for the prosthetics that the adult joint surgeons are going to need to use. So I know that's a long-winded answer, but so I would say I would hope that our kids can get into their early 20s without a hip replacement and without significant symptoms.
Okay, we've got a similar question that you may have partially answered, and you can clarify if you think it has answered it. We have more than one child with MPS. Orthopedic surgeon indicated for them that surgery can be problematic because the bones may not remain stable. Is there a certain time in growth where it is optimal, or are there specific things that can be done to improve stability? Should we just wait until they are as old as possible or do it sooner?
There's not a good answer to that question. So I've been less aggressive about the Morquio patients. Just because I don't know that the long-term outcomes are as good because they tend to have more instability due to the joint laxity. But with that said, I think there's benefit to getting them stabilized, and there's not really anything other to do except to make sure that the bones are well aligned and in place.
Okay. Thank you. This is for Dr. Orchard. Have you seen an MPS 1 transplant child several years ago be fully engrafted, but see enzyme levels in the lower side? And if so, would gene therapy help these kids?
Yeah, so there's a fair amount of variation in what the enzyme levels look like after transplant for reasons that we don't understand as well, certainly as I would like. I mean, clearly, if a transplant is done with a sibling who's a carrier, then you'd anticipate that the enzyme levels are going to be lower. But even in those that are transplanted with unrelated donors or cord blood grafts where, the assumption is that they aren't carriers, there's a lot of variation. How well that actually correlates to outcomes is still a bit unclear. I showed a little bit of data suggested for some of these orthopedic related issues. If you have more enzyme, you might get a bit or be less likely to need some interventions. But, that data is not as straightforward as we would like. It seems, though, that there is a bit of a dose effect, as I kind of alluded to. So, if we can get 10-fold better enzyme, hopefully we'll have an increased likelihood of slowing the disease progression down. And there's a lot we don't really understand. Klane maybe understands this much better than I do, but we don't even really know exactly what's going on in terms of the skeleton. Is the accumulation of glycosaminoglycan directly affecting the bone growth, what the epiphyses are doing and whatnot, or is it secondary effects related to inflammation and other, indirect mechanisms? That's still not clear to me. And there's been different interventions to try to decrease inflammation and see if that would make things better as well. But globally, it seems like if we get more enzyme, we'll probably get better outcomes. And so that's one of the approaches we're really looking at.
Okay, thank you, Dr. Orchard. Again, if a patient underwent a BMT in the past and loses engraftment, will they be eligible for a gene therapy lentiviral transplant instead?
My guess is that the first protocols with the lentiviral-based gene therapy are going to be in naive patients, so they're likely to restrict eligibility to patients that haven't previously been transplanted. So the protocols aren't written. The pilot was done in Milan, as I kind of alluded to, but the second sets of studies are not fully mapped out. But again, my guess would be that they would likely restrict it to newly diagnosed patients. The Regenix Bio protocol could be used, I think, in patients that have previously gone through transplant, and the ImmuSoft protocol maybe as well, but I don't know that the lentiviral one will be.
Okay, thank you. Dr. White, what are the long-term outcomes and possible complications and frequency for young MPS patients who undergo cervical laminectomy and fusion, possibly occipital fusion?
Quite honestly, the long-term outcomes, if the surgery, is done appropriately and successfully, and again, that varies depending on their needs, as I've already talked about, in terms of whether you fuse an instrument or not. But as long as you sort of follow those guidelines, they tend to do well for a very long time. There is a small percentage, even if you do a fusion, who will have recurrent narrowing of the spinal canal. And so but that's pretty uncommon. I would say that the majority of the kids that I follow have done well long term. Short term, there's always a risk of complications with surgery, specifically neurologic injury, but also infection and other respiratory or other surgical complications. But again, if you're in a center that is able and willing to deal with those problems, it can be done well and it can be done safely.
Okay, thank you. Dr. White, again, for a child who has had carpal tunnel surgery, what would you suggest on follow-up nerve conduction studies? In other words, how long after surgery should we recheck?
Yeah, so there are actually quite a few reports of recurrent carpal tunnel syndrome after carpal tunnel release. So I do believe that some kind of surveillance afterwards is appropriate. It largely depends on the developmental and cognitive ability of the child to tell us whether they're having symptoms or not. And if they're old enough or developmentally appropriate enough to tell us about their symptoms, then I typically will not do nerve conduction studies, at least not often. I might do it in a few years afterwards. But in those children who cannot, then I would say probably a year or two after surgery first of all, just for surveillance, but secondly, to see whether there's any improvement in the nerve function. So you probably want to have some kind of outcome measurement. But that said, because I just kind of contradicted myself, but you don't necessarily expect to see a lot of change or improvement. It's really, you want to just keep it from getting worse. So, but I think some kind of surveillance is probably appropriate at a year or two. But I don't know that you necessarily have to, I guess, is the bottom line. Because many of the kids, you have to balance this with some of the kids, they need to have sedation to have the studies done. So you have to be a little thoughtful about it. There's not a black and white answer.
Okay.
Yeah, if I could just chime in a little bit quick too. So generally the kids that come back and seeing us long term, we have them see the hand surgeons every couple of years at least. So, I mean, the carpal tunnel issues are one set of issues, but sometimes the kids develop significant buildup of storage material on their fingers and tendons, and they need to have other things done as well. So we, not maybe every year certainly, but every few years we tend to at least have someone take a look at them.
Okay. Thank you, gentlemen, for all your answers. We received over 20 questions. Those that have not been answered will be given to the doctors to be answered via email. I want to remind everyone that we start back up next Saturday at noon Eastern. And we have over 540 registrations from 20 different countries. So it's been a phenomenal response to this. And we look forward to seeing everyone on Saturday. Thank you.
Good. Thanks.
Thank you, Steve. Happy Father's Day, everyone.
Yeah.
Yes.
All right.